Okay, hi. This is the presentation, the TED Talk presentation on ventilation reform. This presentation has evolved over time, and so this is the current version of it. And we'll start at the beginning, at least the beginning for me. So back in 2011, which was right when I started working for Kaiser, we held a design contest. It was called Small Hospital Big Idea. We asked designers to dream up the hospital of the future, and we narrowed it down to three finalists. The finalists put together full-blown proposals. What was amazing for me was that all three finalists proposed net zero hospitals. All three of them said that the hospital of the future would be a net zero building. And so my boss at the time told me, you better get out in front of this net zero hospital thing. All these guys talked about net zero hospitals, and our leadership loved it. It's totally lined up with our brand. It's totally lined up with our public image. And so this is coming, and you better figure it out. And of course, one thing that we have is we have a big portfolio full of buildings. And so we've looked at that portfolio because we have all the data. And what we could say about the portfolio is that if you could cover 10% to 25% of a hospital's site in solar panels, then to zero out the energy, you'd need to get your consumption down between about 40 and 110 kBTU per square foot per year for net zero. So the number that I have picked is the number right in the middle of that. I like to say that the target for a net zero hospital is 65 kBTU per square foot per year. That's what I call the net zero target. And those units, of course, kBTU per square foot per year is a pretty common metric. We call that EUI, or Energy Use Index, because there's lots of national and state data available, and Kaiser uses EUI to benchmark all of our facilities. So where are we now? Right, the target's 65. Well, right now we're really, really high. The national average U.S. hospital is 230 kBTU per square foot per year. So we're looking for a 75% or 80% reduction to get towards that net zero capable target. So sometimes I talk to ASHRAE people and they say, oh, we need to take baby steps. Maybe let's try to change this one little thing in 2018 and we'll change another little thing in 2021. But baby steps is not the name of the game. If we want to hit net zero or get near net zero by 2025 or 2030, then we need to identify the problem and hit it hard. The good news is the problem is easy to find. Um, Here's the quick 411 on hospital energy. About 10% of our energy goes to the lights, 20% of the energy goes to medical equipment and process equipment, and then the other 75 is HVAC energy. Typical U.S. hospital, 2/3 to 3/4 of the annual energy goes to HVAC. That's really where it goes. It's kind of that simple. It is hard to overstate how different this is from other buildings. It always sounds like I'm exaggerating, but I'm not. If you built a 200-bed luxury hotel and then built a 200-bed hospital right next to it, same size building, the annual HVAC energy in the hospital will be 5 times that of the hotel. So it's not like it's 20% higher or 30% higher, it's 5 times, 500% higher. That is primarily because the hotel would not design the HVAC systems using a mandatory minimum air change per hour table like this. The hotel would design systems to keep people comfortable, to control odors, to maintain acceptable indoor air quality. There's nothing dangerous about the air in the hotel. But we use this. We use this table of air change rates. And we exclusively use this. We do not allow any alternative approaches to using this. So the question that we've been asking is why? Why do we do this? And that's where my team has been looking for about the last 5 years. Our research, quote unquote research, falls into three lines of inquiry. First off, we've been comparing the numbers that you get under the air change method to the numbers that you get using contemporary design methods for air quality and odor control and comfort. Very different sets of numbers, right? Second, we've been comparing international hospital ventilation. In North America, we like to use these air change tables, But as you look around the world, there's different approaches in different countries. And then finally, we've been doing the stuff that actually has gotten the most, reading are these history papers. Because some of the numbers in the tables have stories behind them, and we can actually tell those stories. A lot of them are rules of thumb that date back to the 1960s, and some of them are rules of thumb that date back, further to the 1860s. Unfortunately, that's not a joke. The single most common number in the air change table is 2 air changes per hour, and we actually did trace that all the way back to the 1870s, just after Florence Nightingale's sanitation reform work in the 1860s. So this is a number that's been kicking around our codes for 140 years, and frankly, it wasn't a really scientific number back then. It was a rule of thumb so that architects could put in enough operable windows for natural ventilation, which of course, by a fun twist of irony, most of the U.S. we no longer allow natural ventilation in hospitals, but that's a whole different story. What we want to talk about is infection control. Because what you're probably thinking, or what you've heard, is that the air change rates that we have in this table have something to do with infections. And that's an area where there's a little bit of truth, and then a lot of mythology, and a whole bunch of fear. First off, there are areas in hospitals where HVAC practices have some sort of tie to the clinical outcomes that we're looking for. Operating rooms, we want clean air to mitigate surgical site infections. In protective environments for transplant recipients or severely immune compromised folks, we want to clean the air to mitigate opportunistic infections. There are also legitimately sterile areas like pharmacy compounding where the air needs to be clean. And then we have airborne isolation spaces, short-term and long-term. When airborne cases show up, we isolate them into a room that's exhausted. We have negative pressure in those rooms. And you'll notice you can put clinical citations on all of that, right? That is all good. And any international standard that you look at will honor all of these principles. There's no such thing as a hospital in the developed world where these things are not getting done, right? The mythology happens outside of these spaces. Us U.S. engineers, including myself, for most of my life, believe that in the general idea that general ventilation rates will reduce general infection rates. And that sounds really noble and it sounds really good, but it's just unfortunately not true. It doesn't hold up to scrutiny. Let me walk you through an example. One of the high prevalence infection in the U.S. In the most recent data is urinary tract infections. It's right down at the bottom. No change, right? We call this CAUTI, catheter-associated urinary tract infections. We call it that because they're generally associated with catheters. So you just think about that for a second. How could an air conditioning system possibly prevent a urinary tract infection? Or conversely, how could an air conditioning system cause a urinary tract infection? And the answer is that doesn't make a whole lot of sense because there's no interaction between air conditioning systems and urinary tracts. Hopefully you're keeping your urinary tracts under the covers and out of the direct line of the air conditioning. Now, I have actually heard HVAC engineers say that particles could fall out of the air, land on a surface, get onto the hands of the healthcare workers, and then get into the urinary tract. And yeah, I guess that is kind of true, but it's also a stretch. There's no data on it. There's no science on that. And all you have to do to break that chain of infection is to wash your hands before you touch the catheter. And by the way, the #1 recommendation for preventing catheter infections is to wash your hands before you touch the catheter. You can read every infection control guideline in the world on urinary tract infections, and I've done that, and none of them mention HVAC. Nobody puts HVAC in the top 10 list of things to do to prevent urinary tract infections. It's just not even a factor. When I talk to audiences, and I give this presentation to audiences in rooms, I use urinary tracts as that example because it's easy to picture. Okay, I get it. HVAC is pretty irrelevant. But the same is true for most of these other infections outside of the operating room, right? Bloodstream infections are most commonly associated with needles. Ventilator-associated pneumonia is called ventilator-associated pneumonia because it's most commonly associated with respiratory equipment or breathing tubes. And MRSA and C. diff, When you dig into the real infection control guidelines, those are not about HVAC. HVAC is not a real component in preventing or causing those infections. But most of my people, the HVAC engineers, are really scared. We've been using these air change rates for a lot of years, and if you reduce the air, oh my God, you might cause infections. I believed that for a lot of years, that this hospital stuff was based on infections. But it's just not an idea that holds up to investigation. And by the way, that's not for lack of trying. I've been giving this presentation to HVAC engineers for a couple years. There's always a guy in the room who says, oh, I swear I saw that there was some research that showed this connection between this and that, or whatever it is. And I always say, send it to me, right? Because I collect them. I collect them all, and I have a fairly huge collection. There is no lack of research. There's actually a ton of it. We keep studying this over and over and over and over. And unfortunately, there's just no gold in the river. You can look as long as you want. One thing we do know, these, by the way, are all the meta studies. These are not the individual papers. These are the multidisciplinary research teams that have gotten together and looked at hundreds of papers to try to draw general conclusions. The one thing we do know, if you have dirty air or contaminated air, that's a problem. And that's kind of what that quote at the bottom from the World Health Organization says. So we do need good air quality. Of course we need good air quality. All commercial spaces, all residential spaces need acceptable indoor air quality. Everybody likes good air quality. But what we don't need is we don't need a whole bunch of extra air in our healthcare spaces. And let me show you what I mean by extra air. This is the pilot project that we did in Los Angeles with Dave Castillo. This is a sample room, labor and delivery room, and Los Angeles is a cooling climate, so the air we need in the room is largely driven by the cooling load. So you see those mountains showing the air and the load in the room, right? The red line is a summer day, and the blue line is a winter day, and the horizontal lines are the code and standard line. For hygiene level ventilation, 15 CFM per person, or the alternate two variable approach, those are the lower lines, the dotted lines down at the bottom of the chart. Now, California says that if you use 100% outside air, the minimum ventilation rate is 2 air changes per hour. That's the gray line down at the bottom. But the national standard 170 says minimum ventilation is 6 air changes per hour, 24/7. That's the line at the top of the page. And you can kind of see that on a summer afternoon, that's an appropriate ventilation rate. We want that much ventilation on a summer afternoon. The rest of the time, it overventilates the room because the code sets the minimum ventilation rate, or the turn down position. That's how much air you have to use at night during economizer hours when the patient is asleep. And in those areas, we're overdoing that by a lot. So this project was one that we did with Dave Castillo, and we used 2 air changes per hour during all the economizer hours, and that alone was worth a 70% savings in HVAC energy. It's a big deal. It's a really big deal. But what's more interesting still is to take a look around the world at labor and delivery spaces, right? What are all the different requirements you could find? The French are the strictest. They call it a risk category 3. So they're actually validating particle counts and microbial counts when they get into labor and delivery spaces. I think that's excessive. The UK, for whatever reason, wants 15 air changes per hour. I think that's a carryover from when they were doing surgeries in the LDR rooms. Because look, you can have a baby at home, right? I have this coworker, Gretchen, who was thinking about having a baby at home, and you can go onto Google and you can look up pros and cons of home birth, and you find a whole bunch of reasons why you might want to have a baby at a hospital. She obviously decided to have a baby at a hospital. But one of the reasons that you won't find is HVAC, because moms that are considering having a baby at home versus a hospital don't care about HVAC or air change rates. It just doesn't matter. The lowest numbers that you find internationally are in the German book. In Germany, they don't treat birthing as a specialty ventilation space. They just say, design the system for comfort, design the system for air quality, and there's no extra requirements. That's also true in Japan and Scandinavia. That German code actually gets adopted into a number of spaces. And by the way, that also generally means natural ventilation. Germany is very big on natural ventilation. The point here is that we have this number in, the national standard, 6 air changes per hour, right? And we say ostensibly that's a safety number. 6 air changes per hour is safe and 5 air changes per hour is not safe. Well, obviously that's not true. It's just not true, right? When I give this presentation, I talk about the labor and delivery room example, and I like using that example. I don't talk about operating rooms and isolation rooms, and I do that on purpose. This is our Fontana Medical Center. This campus is 1.6 million square foot of space. We have ORs, we have isolation rooms, and we have critical spaces on this campus, and they make up about 200,000 square foot of space. That's less than 15%, which is to say there are 1.4 million square foot of non-critical spaces at this campus. You've got your 6 air changes per hour in your LDRP rooms, your 6 air changes in the patient rooms, 6 air changes in exam rooms, 6 air changes in x-ray rooms and diagnostic areas, 4 air changes in the hallways. That's what's killing the energy signature. I tell HVAC guys in the presentations, I say, forget about the ORs. It's a red herring. Sure, you can save a bunch of energy in an individual OR by doing turn downs and temperature resets and all that stuff, but you will never see that on the bills. If you want to have a measurable impact on the energy bills at this campus, you've got to go after the most common spaces, those patient rooms, those hallways, the D&T exam rooms, bathrooms. That's where the energy's at. Okay, so let's talk about code. And by code, I mean model code ASHRAE 170. So imagine walking into a fundamentalist Bible church and holding up a copy of the Bible and saying, hey, I've been reading this book and there's a whole bunch of wrong stuff in here. We should really rewrite it. Yeah, that's pretty much basically exactly the response we've gotten in the last 5 years from ASHRAE. We've been having that conversation in ASHRAE since about 2012, and it has not been pleasant by any stretch of the imagination. The committee wanted a second opinion, of course. So right now, ASHE and ASHRAE and FGI have a research project for, quote, academic research to support FGI, ANSI, ASHRAE Standard 170. It's kind of an amazing research project. The research team identified 880-something requirements in Standard 170, and then they collected 740 engineering, scientific, and research papers, and they're grading the level of evidence that they find for each line item. It's wild. In Long Beach, these guys presented the night before the main meeting, and it's amazing to see. So by mid-18, there will be a nice big report on ASHRAE letterhead showing the evidence basis of the requirements behind Standard 170, or, spoiler alert, a lot of those requirements are going to be shown to have very low evidence basis behind them. And of course, once that report comes out, the committee is just going to jump up and change all the requirements, right? No, they're not. What's really going to happen is, they're going to want to hold on to those requirements. And we're going to press. I can tell you from my perspective, before the ink is dry on that report, we're going to be submitting public comments and change proposals and action items, telling them to roll back any requirement that we don't have a reasonable amount of evidence to support. So let me get back to energy for a second, because this is a really fun story. These are Kaiser outpatient buildings. The names have been changed because I do present this in public, and this is also a sampling. We have 200 outpatient facilities, and I'm only showing 20. But you look at the energy signatures here, and again, this is energy per square foot. And what you're seeing here is that group of buildings up at the top with energy signatures that look a lot like hospitals, and then you're seeing another group of buildings with energy signatures that look a lot like offices. We found this phenomenon about 5 years ago. And first we thought it might be certain departments, or it might be certain services, and it's not. We thought it might be year of construction. It's not. What's happening here is that the buildings up at the top were designed using the air change tables. In outpatient facilities, that is not code, but some designers do it anyway. It increases first cost a little bit because you have those pressure requirements and ducted returns and things like that. And then you have the buildings down at the bottom that don't use the air change table. They're actually less expensive buildings because they're designed like offices or schools or any other commercial space. And they use less energy, right? So you've got one set of buildings that uses air changes, costs more, uses more energy. The other set of buildings that doesn't use air changes, costs less, and uses less energy. So the big question is, are the more energy intense buildings better? Do they have happier occupants or better patient outcomes? And of course the answer is no. The medical groups in the buildings have no idea this is going on. They literally don't know the difference between the buildings. We made that our rule. In outpatient facilities, state by state, building by building, room by room, if we're not legally required to use an air change rate, we don't. And that has helped a lot because nowadays we're designing our outpatient buildings for energy intensity of 40 or 50. I am perfectly comfortable predicting that we will be fully net zero capable in our outpatient buildings by 2020. Easy. And there's nothing razzle-dazzle about the HVAC systems that we're putting in there. We're just putting in reasonably efficient, cost-effective VAV systems. Come and see some of these buildings. We are super proud of them. And so this is in the hospital space. Obviously, in California, we have to use air changes in administrative spaces in retail and cafeteria and things like that, but the other states don't require that. And so at our hospital in Oregon, our facility engineering team simply reprogrammed the systems for more turn down. It wasn't even a capital project. Our guy did it with his computer and with a couple of staff air balance techs over a few weekends. He got immediate savings and pretty big savings. He told us that right when he put the new settings in place and converted the systems to VAV, the fans ramped down to 40%. They've been tracking there ever since. And he actually says that comfort complaints went down. It's less drafty and there's fewer pressure issues in the building. Of course, now we have the dream project, right? What we're doing is putting together a team of engineers, industrial hygienists, occupational safety folks, and infection control, developing a set of threshold air contamination level. And the plan is to do continuous monitoring using a combination of sensors in the space plus some boots on the ground monitoring. If we can measure our environment real time and manage our environment real time, then you really don't even need prescribed ventilation rates. You simply operate your system as needed to get the environment that you want to have and document it the whole time. The energy savings potential in this idea is pretty massive. But to me, what's maybe cooler is that our environmental health and safety folks and our infection control folks, this is a better idea. This is a step up in environmental awareness because hospitals almost never measure air quality, let alone continuously measure air quality. So to continuously and proactively measure air quality, even if it's just a few variables, would be huge. So that's kind of the presentation. If we're going to get to net zero, we need to hit the design of air conditioning. I've seen the enemy, and the enemy is me. He's the HVAC engineer. I am to blame for the energy signature of hospitals, but I totally believe that we have the tools, we have the smarts, we have the technology, we just need to start using them. There are a lot of barriers. I think that hospitals, regulators, and most design engineers like the level of regulation in hospitals. Because if engineers don't have any choices, they can't screw it up or they're less liable, right? And no, that's actually not true, but that is a very common perception. And there are those who will tell you that the tables work fine, right? We've been using those air change tables successfully for however many years. But I say no to that. The energy signature of U.S. hospitals is not successful, and I know that we can do better. I know that we can do a lot better.